Hi friends, today I am going to discuss about a very interesting topic, that is gynecology and obstetric conditions. First comes delayed menarche. Menstrual cycle usually establishes at the age of 16 years but may be delayed up to 18 years of age, but a girl is usually brought for investigations at a much earlier age. We can make two broad categories: primary amenorrhea with secondary sex characters not developed, refer as cause is most probably endocrinal or developmental. Primary amenorrhea with secondary sex characters developed, girl with normal build, the cause is most probably imperforate hymen, absent or underdeveloped uterus. Do USG if uterus is underdeveloped, needs hormonal treatment, that is tablet estrogen plus progesterone, that is overall for 21 days, or tablet ethinyl estradiol, that is linerol 0.05 mg TDS for 21 days. Try for not more than 3 cycles, refer if regular menses, fails to get established if imperforate hymen, refer for surgery. In obese girl, for delayed menarche, do TSH to rule out hyperthyroidism, do USG to rule out PCOD, polycystic ovarian disease, adrenogenital tumor. If normal, treatments same as in primary amenorrhea with secondary sex characters developed, that is estrogen oral or linerol. For obese girl also the treatment remains the same. Then if normal treatment is there and advise weight reduction, this may by itself establish menses. Thin girl, do T3 T4 TSH to rule out hyperthyroidism, do X-ray chest to rule out tuberculosis. If normal, advise improvement in general health and treat as same as earlier, like linerol and oral. And abnormal and excessive uterine hemorrhage. Abnormality can be in the form of change in cyclicity or change in amount and duration. Accordingly, we can divide it for 4 types: menorrhagia, cyclic but amount and duration increased, 5 to 28 days and 8 to 28 days. Cause mostly lies in the uterus, fibroid or adenomyosis, etc. Try hemostatic therapy first: tablet ethamsilate, silate 500 mg TDS or QID, or tablet gynaec CVP TDS, or tablet stardren CKP 1 to 2 TDS, tablet tranexamic acid 500 mg 1 to TDS, or injection streptochrome 2 ml if severe, plus tablet mefenamic acid, that is mephthol or ponstone 500 mg TDS. If no relief, give hormonal treatment: tablet northestrone acetate regestrone 5 mg 1 TDS for 3 days, then 1 BD for 3 days, then 1 OD for 15 days. This is for excessive and abnormal uterine bleeding, uterine hemorrhage. If no response in 3 cycle, investigate HP with platelet count and BTCT, that is bleeding disorders, USG for fibroid, bicornuate uterus, T3 T4 TSH, hypo or hypothyroidism. If all investigations are normal, advise curettage as a last resort, which can be therapeutic. In polymenorrhea, cyclical pattern changed about amount normal 5 to 21 days, 5 to 18 days. Menses will be on and often in one cycle. Cause lies in the ovaries, congestion, infection, endometriosis, etc. Commonly seen for few cycles after pregnancy, following menarche and preceding menopause. Reassurance for 3 cycles, hormonal treatment as given above if no improvement. Polymenorrhagia, cyclical bleeding more frequent and excessive, 9 to 20 days, 12 to 20 days. Disturbance in HPOA axis as well as in uterus, example PID. Do USG treatment same as for menorrhagia, plus give treatment for PID, that is tablet ciprofloxacin cifran 500 mg BD plus tablet metronidazole metrogil 400 mg TDS, plus doxycyclamine, that is doxy 100 mg BD for 7 to 10 days, or azithromycin 500 mg plus secnidazole 2 mg plus cefixime 200 mg, that is acetic stat. Here what they are explaining is, in polymenorrhagia it may be associated with infection, so treat cycle disorders along with infection like PID. Next comes metrorrhagia. Metrorrhagia is cyclicity lost and amount variable, irregular or continuous, mostly due to surface lesions of the genital tract from vulva to endometrium. Do PS to rule out, PS is per spectrum, to rule out local lesions of vulva, vagina, cervix and uterus. Treat according to the cause found. Do USG. Refer if it shows conception products in uterus, ectopic gestation, cystic ovaries, etc. Refer for diagnostic curettage if no cause found. Metrorrhagia means cyclicity has been lost and amount also is variable and very irregular or maybe continuous. So you have to do per spectrum and then curettage and search for any gestational products. For satisfactory treatment, determine the cause and treat. No shooting in the dark. Younger the patient, more are the chances of menstrual disorder being functional and cure spontaneous. In the reproductive age group, always think of pregnancy related conditions like abortions, PID, etc. After the age of 40, functional disturbances are common but need complete evaluation to rule out malignancy. The more irregular the bleeding, the more need for investigations and curettage. Any postmenopausal bleeding episode warrants thorough investigations to rule out malignancy. Excessive and prolonged bleeding is never a feature of approaching menopause. Next comes dysmenorrhea. It is important to determine the type of dysmenorrhea. The pain arising from the uterus is true or spasmodic dysmenorrhea. The pain which is due to pelvic organ or tissue other than uterus and is merely associated with menses in congestive dysmenorrhea. True dysmenorrhea. It is a first day pain during menses, though it may start a day or two prior. It occurs in 18 to 25-year age group and spontaneous cure after pregnancy is very commonly seen. Advise rest, give anti-inflammatory drugs first, tablet mefenamic acid plus dicyclomine meftalspas. If no relief, start hormonal treatment. Tablet estrogen plus progesterone oral LOD from 5 to 25 days of menses to suppress ovulation and hence pain. If spasmodic dysmenorrhea is unilateral, advise USG to rule out uterine malformation. Dilatation of cervix or paracervical block if no response to medical treatment. Congestive dysmenorrhea. Pain starts 2 to 3 days before menses and reduces with the flow. It is a dull pelvic pain with backache. Advise USG to rule out PID, myomatous, etc. If there is evidence of PID clinically and or on USG, treat for PID. If no relief, give tablet orally LOD from 5 to 25 days of menses for 3 cycles. Pain in endometriosis. Here pain starts 2 to 3 days before the menses and reaches its climax at the end of menses. Do USG, give tablet registrone 5 mg from 5th to 25th day of menses for 3 cycles. If no response, refer. So we have to differential diagnose exactly between endometriosis and congestive dysmenorrhea. In congestive dysmenorrhea also pain starts 2 to 3 days before menses and reduces with the flow, and in endometriosis also pain starts 2 to 3 days before the menses and reaches the climax at the end of menses. So differential diagnosis should be done properly. Next comes preponement and postponement of menses. Religious functions, sports, activity, marriage, honeymoon, etc. Few of the reasons with which patients come to seek advice as how to prepone or postpone their menses. Postponement is more reliable than preponement. To prepone, tablet estrogen plus progesterone oral OD from 5th to 14th day of menstrual cycle, or tablet ethinyl estradiol, that is linorol 0.05 mg TDS from 5th to 14th day of menstrual cycle. This will prepone the menses by 1 week. Tablet ranitidine, that is Zintac 300 mg OD to prevent gastritis along with oral L. Then to postpone, tablet estrogen plus progesterone oral L OD or tablet northestrone acetate regestrone 5 mg BD at least 3 days before the expected date. Continue as long as postponement is desired, usually not exceeding more than 10 to 12 days. Tablet ranitidine 300 mg OD along with that. Next comes vaginal discharge. It is one of the most common complaints in females worldwide. It gets the discredit of being the cause of many complaints like weakness, backache, etc. But it is not always pathological. Normal vaginal discharge is that which is enough to keep the introitus moist. It is white or cream in color and may stain the underclothing brownish yellow. It is non-offensive and non-pruritic. It is more in ovulation, during pregnancy, before menses, and during sexual excitement. Give firm reassurance. Advised to keep herself busy instead of concentrating on vaginal discharge. Abnormal vaginal discharge may be due to change in quality or quantity or both. Increased normal discharge, that is leukorrhea. Do PV examination to rule out local conditions like cervical erosions, polyp, tumors, etc. Treat the cause. If no local lesion found, reassure, advise good genital hygiene, improve general health, try to reduce anxiety. Abnormal discharge with pruritus. Cause is usually trichomonal or candidial vaginitis. Treat as given in pruritus vulvae. Abnormal discharge with pruritus. It may be trichomonal or candidial vaginitis. Abnormal discharge with burning micturition. Cause is mostly gonococcal infection. Give tablet Cifran 500 mg single dose. Abnormal discharge with burning micturition. Give ciprofloxacin. That will be gonococcal infection. Abnormal discharge with pelvic pain is usually due to PID. Give treatment as given in above section for PID. Any postmenopausal vaginal discharge, especially if blood stained, do pap smear to rule out malignancy. If pap smear is negative, treat as given in senile vaginitis. This is abnormal discharge with pelvic pain. Pap smear and then treat as senile vaginitis. Pruritus vulvae. It is one of the most irritating and socially unaesthetic complaint. It is equally irritating for the treating physician as the list of causes of pruritus vulvae is a long one. We can make two broad categories. Pruritus vulvae with vaginal discharge 80%. Most common causes are candidial, especially in diabetes, after antibiotics, during pregnancy, etc., or trichomonal vaginitis postmenstrual. Treat for both. Pruritus vulvae with vaginal discharge may be after pregnancy, after antibiotics, or else in diabetic patients. Treat for both, for trichomonal and candidial, both you can treat. Treat with the metronidazole 400 mg flagyl BD for 7 days, fluconazole 150 mg stat, or clotrimazole vaginal pastries candid V3 for 3 nights, and clotrimazole plus beclomethasone dipropionate cream candid B apply 2 times a day. Do BSL to rule out DM. Treat the sexual partner also and advise abs finance until treatment continues. Pruritus vulvae without vaginal discharge 20%. Skin diseases are ruled out by doing local examination. Itching can be due to scabies, pediculosis, threadworm, tinea cruris, contact dermatitis, deodorants, soaps, synthetic underclothing, etc. Treatment of each of these conditions are given in further chapters. In atrophic vaginitis, give estrogen cream, that is Evalon BD. If no local lesion seen, rule out diabetes, glycosuria. Per se can cause pruritus. Treat symptomatically if one of the above present. Tablet cetirizine 10 mg OD, clobetasol, butyrate plus meconazole cream, Umazon M BD. Next comes climacteric menopausal symptoms. Though used climacteric symptoms, that is menopausal symptoms, though used synonymously, climacteric is not the same as menopause. Menopause means the time when menses ceases, which usually occurs between 45 to 50 years, average 47 year. Menopause before 40 year or after 55 year is considered abnormal and needs investigation. Climacteric is the phase of waning of the ovarian functions, which starts 2 to 3 years before menopause and continues for 2 to 5 years after menopause. Common complaints during climacteric are hot flushes with sweating. If severe to interfere with daily activities, start with tablet ethanyl estradiol, that is linarol 0.01 mg OD, or tablet ethanyl estradiol plus desogestrel familon OD. Tablet conjugated estrogens Premarin 0.625 mg OD. Supplement with tablet regesterone 5 mg OD. Tablet Manozone Himalaya 1 BD for a month, then 1 OD. Gradually increase the dose and maintain on a dose which is just enough to reduce flushes for 3 to 4 per day. The final dose is maintained for more than a month, and then the drug should be tapered off slowly over a period of 3 to 4 months. Watch for a month if symptoms repair, restart. Or ethanyl estradiol, that is Estraderm MX patch 25 mcg, 50 mcg, 100 mcg can be used. Alternatively, it is used on non-hairy areas of the skin below the waist. It is to be replaced every 3 to 4 days. 2 patches per week, and each time the site has to be changed. Patches are to be discontinued when flushes reduce. Avoid hot baths, tea, coffee, spicy food, and working near fireplace. Next comes senile or atrophic vaginitis, which means it causes itching, discharge, dyspareunia, etc. Avalon cream once a day for 7 days, then bi-weekly for 7 days, then once a week lifelong. That is senile atrophic vaginitis, means as the age advances, means as the lady grows old, there will be itching in the vagina due to dryness and less estrogen formation in the body. So you have to apply Evalon cream lifelong, at least once a day or once in a week for lifelong. Osteoporosis, tablet calcium carbonate Ocal 500 mg OD plus. This is for osteoporosis, which means less calcium present in the body. Vitcofol D3 calcirol granules 60,000 IU 1 gram sachet per week for 8 weeks, 150 mg per week. Tablet alendronate osteophos on empty stomach with glass of water. Advised not to eat or lie down for 1 hour after taking the medicine. Tablet tibolin, that is Leviel 2.5 mg OD. Advised diet rich in soybean which contains natural estrogens. Advised exercise to prevent osteoporosis. Next comes psychological or neurotic symptoms. This means irritability, depression, headaches, palpitations, precordial pain, paresthesia, in hands and feet, giddiness, etc. Tablet alprazolam, it is Restil 0.5 mg BD or HS tablet, fluoxetine Fluidact 20 mg OD, active listening, thorough examination to rule out organic cause and firm reassurance, that is psychological or neurotic symptoms which makes them irritable, depression, headaches, palpitations and all. Next, after the age of 45-year, advice monthly self breast examination, yearly bimanual pelvic examination, yearly pap smear after 45 years, yearly mammography, no HRT as prophylaxis, its risk CA uterus, CA breast, thromboembolism, CHD, etc. Overweigh the benefits, prevent osteoporosis. Thorough investigations to rule out malignancy of genital organs if there is postmenopausal bleeding, any bleeding after a gap of 6 months or blood stained vaginal discharge. Advice for contraception. Methods of contraception. Many methods of contraception are available and the choice depends on the circumstances in which it has to be applied and on its acceptance by the patient. First one comes oral contraceptive pills and depots. This would be the best choice for young women below 35 years, especially newly married women, as here the contraceptive measure is independent of the sexual act. The tablet, oral L or triquilar or Maladi estrogen plus progesterone from 5th day of menses for 21 days, or injection northestrone anathate noristerate 200 mg 1 ml every 8 weeks to be given on the 5th day of menses. Every 8 weeks means after every 2 months you have to give this northestrone anathate, that is noristerate 200 mg 1 ml injection on 5th day of menses. Next comes injection medroxyprogesterone Depo-Provera 150 mg 1 ml every 3 months to be given on the 5th day of menses. Medroxyprogesterone is practiced everywhere nowadays. The depot preparations have the advantage of not having to take the pills every day, but uncertain and acyclical breakthrough bleeding can occur and is many times unacceptable, especially in religious settings. OC pills should be taken after meals or with milk to avoid gastritis. The patient on OC pills should be warned to use some barrier contraceptive method during the first cycle, as it may be ovular. Alternative OC pills can be started a month or two before marriage. After 6 months cycles of OC pills, a gap of 1 month is advised to safeguard against adverse effects. Every 6 months, patient should give a gap of 1 month without OC pills to avoid adverse effect of those OC pills. Next comes IUCDs, that is intrauterine contraceptive device. It is a method preferred for spacing between two children. CUT200, that is copper T200, copper T350, multi-load copper T250, copper based IUCDs, effective for 2 to 3 years. Next comes, these are copper Ts. Next comes progesterone based IUCDs, effective for 8 to 10 years. These IUCDs contains progesterone in them. It will last for 8 to 10 years. IUCDs can be inserted 6 weeks after delivery or abortion, 12 weeks after cesarean section, or on 5th day of menses. Inserting IUCD is not a difficult procedure which can be learnt and practiced by a GP. Intermenstrual spotting, menorrhagia and dysmenorrhagia are common side effects and the patient should be warned before. Next is a barrier method, that is condoms or Kama Sutras. Have the benefit of giving protection against STDs along with contraception. This method is advocated if other methods are not acceptable for medical or other reasons, but its failure rate is very high. Female condoms, Femidome, have not gained much acceptance and are not freely available. Next comes permanent contraception, that is tubectomy or vasectomy. These methods of permanent contraception are adopted when the family is complete. Vasectomy is much simpler and less hazardous procedure as compared to tubectomy. It can be done under local anesthesia without hospitalization. Next is the safe period for contraception. It is advocated for the couples not using any other contraceptive method and is far from being safe. It is applicable only if the woman has regular menstrual cycles. In a 28-day cycle, the safe period is 4 days of menstrual flow, 3 days post-menstrually and 9 days premenstrually. If the cycle is shorter than 28 days, time must be subtracted from the post-menstrual safe period. When it is longer than 28 days, time can be added to this phase. Next, lump in the breast. Confirm whether there is lump or not. Frequently, there is no lump. The normal fat and glandular tissue between fibrous septa is perceived as lump. Confirm the presence or absence if the lump by the flat of your hand. In case of doubtful lump, call after 15 days if patient is in menstrual phase and re-examine to see if lump persists. If lump confirmed, check if there is acute inflammation. If acute inflammation present, treat as given under breast abscess. If no acute inflammation and swelling is cystic, aspirate as given under aspiration technique. Refer if aspirate is blood stained, cyst refill, there is lump after aspiration. Next, if swelling is non-cystic, firm to hard, smooth, mobile and lobulated, the clinical diagnosis is fibroadenoma. Confirm if in doubt by FNAC, fine needle aspiration cytology, or incision biopsy. Excision biopsy is rarely required. If swelling does not fit in any of the above types, refer to experts for mammography, FNAC, etc. Lump in breast is over, and any lump after menopause is considered malignant unless proved otherwise by mammography, FNAC or biopsy. Signs suggestive of malignancy are lump that is hard, painless, irregular, attached to the skin or underlying muscle mass, nipple retracted with or without axillary lymph nodes. Screening for breast cancer. Screening for breast cancer. The following screening procedure is to be followed for each woman, but more stringently for those with high risk factors like multiparity, having family history of breast cancer, delayed age of first pregnancy, on HRT, etc. Breast self-examination every month on 7th day of menses for women above 40 years. Earlier, if with high risk factors, pamphlets showing how to do this can be provided to the patient. Any new mass, change in size and shape of breast or nipple discharge or skin changes should be reported. Clinical examination of breast by clinician. Any mass felt by the flat of a hand should be investigated. Axillary and supraclavicular nodes should be looked for. Next, mammography every 2 years for women between 40 to 50 year, and every year for those above 50 year and those with high risk of breast cancer should be done for every 2 years. Screening for carcinoma cervix. Who is advised for screening? Every woman above 40 years every year up to the age of 57 years, after which CA cervix is rare. Postmenopausal bleeding, blood stained offensive discharge, postcoital bleeding, any cervical lesion, bleeding on touch, fixed friable indurated cervix, every HIV positive women every year. The screening is done by doing cytodiagnosis either by cervical scrape technique using arrays method or vaginal cytology technique using Papiniopoulos method. These methods are described in later chapters. One half of all the patients of CA cervix present themselves with the growth has already reached incurable stage. Routine screening for CA cervix has been shown to drastically change this scenario. Next comes antenatal care. The ultimate goal of regular antenatal care is healthy mother with a healthy child. The first visit checklist. The first visit can be at just missed period or at labor. Record LMP, last menstrual period, confirm diagnosis clinically or by urine pregnancy test, and calculate EDD, expected date of delivery. EDD is calculated by adding 9 months and 7 days to the first day of LMP. Record age, weight, height, BP, record menstrual and obstetric history, history of abortion, pre-eclampsia, preterm, post-term delivery, type of delivery, puerperium, APH, low birth weight baby, etc. Record if the woman has asthma, HT, hypertension, diabetes mellitus, epilepsy, rheumatic heart disease, etc. Drug history, especially OC pills, drugs taken for withdrawal, bleeding, vaccines, etc. Investigations like HB, blood group, RH, ELISA for HIV, VDRL, Australia antigen, urine routine, BSL. Checklist for every visit. One visit per month in first 7 months, thereafter every 15 days and weekly after 36 weeks. The visit should be more frequent if there is bad obstetric history. Record BP, pulse and weight. Check for edema, pallor, fundal height, FHS 24 weeks onwards by stethoscope, position, lie and presentation of fetus 36 weeks onwards. If possible, urine albumin at each visit. USG ideally 1 per trimester but at least 1 at 16 to 20 weeks. Routine treatment: tablet folic acid, folate 5 mg OD in first trimester, tablet ferrous fumarate, Otrin OD after second month, tablet calcium carbonate ocal OD, injection TT, tetanus toxoid 2 in last trimester 1 month apart. 1 will suffice if taken in previous pregnancy. Other than drugs, dietary advice: balanced and high protein diet, plenty of green vegetables and fruits, adequate rest, mental as well as physical, regular isotonic exercises, yoga, physiotherapy, breast and nipple care, avoid long journeys in first and last trimester if unavoidable, prefer train, avoid sexual intercourse in first and last trimester or restrict to non-penetrative sex, educate about importance of exclusive breastfeeding and immunization of baby to be born, discuss future contraceptive measures. High risk pregnancies: very young, less than 18 years or old, above 30 years, multiparous, short statured, less than 140 centimeter, obese, bad obstetric history, twin pregnancy, uterine height not corresponding to gestational age, that is IUGR, intrauterine growth retard, FHS not heard at 24 to 26 week, breech or transverse lie at 36 week, head not engaged at 36th week, antepartum hemorrhage, abnormal FHS less than 100 per minute or more than 160 per minute, hypertension, rise in systolic BP by 30 and diastolic by 15 over and above baseline value, edema especially of face, excessive weight gain above 0.5 kg per week, albuminuria, diabetic patients and cardiac disorders. These all are high risk pregnancies. High risk pregnancies require strict monitoring, preferably by an obstetrician. Problems in pregnancy: anemia. No pregnant woman should land in labor in an anemic state. If HB is between 7 to 10 grams per gram percentage, start capsule Otrin, BD or TDS. If not tolerated orally, start injection Imferon 2 ml deep IM alternate days AST. Blood transfusion if required if there is no time for oral treatment. If HB is below 6, PCV is advised. PCV is a packed cell volume blood transfusion. Give tablet no warm 400 mg. That is albendazole. Morning sickness. Very common and very unpleasant symptom. Bed tea with 1 to 2 biscuits or toast, frequent small feeds, tablet vitamin B6 or B long OD, tablet meclizine pregnidoxin 1 to 3 tabs per day, or tablet doxylamine doxyla 2HS or 1 TDS. If not controlled with these measures and vomiting worsens leading to tachycardia with dehydration, admit the patient. She will require IV fluids, especially DNS dextrose 10%, IV 25% dextrose, 4 ampoules daily. Injection multivitamin macraberin 4 1 ampule daily. In preeclampsia, the diagnosis of preeclampsia is made if any of these two conditions are present. If hypertensive, or there is a rise of BP by 30 mmHg systolic and or 15 mmHg diastolic over the above previous reading, even if normotensive. Edema, especially in upper part of the body. Weight gain above 0.5 kg per week. Albuminuria. All these are diagnosed as helps in diagnosis of preeclampsia, high BP. Advice: strict bed rest, especially in left lateral position. Tablet diazepam compose 5 mg 1 to 3 per day. Tablet methyl dopa 250 mg, alpha dopa 1 to 4 tablets per day, or tablet atenolol 50 mg, that is attain 1 to 2 tablets per day. Low salt or salt free diet. Advice: counting of fetal movements should be more than 10 per 12 hours. Regular and stringent fetal monitoring clinically and bi-weekly USG. Refer immediately in the following conditions. BP rises to above 160 per 100 mmHg. Give tablet nifedipine, depine 5 mg sublingually. Headache, vomiting, visual disturbances, epigastric or right hypochondriac pain, reduced fetal movements less than 10 to 12 hours, abnormal less than 10 per for 12 hours, abnormal FHS less than 100 per minute or more than 160 per minute, oliguria, convulsions, then we have to refer them immediately. PV bleeding in first trimester. Confirm it is pregnancy related bleeding and not delayed menses. Bleeding sometimes occurs at menstruation time for first few months in some pregnant women. Advise bed rest. Tablet natural progesterone ETS Naturogest 200 mg BD for 5 days. Tablet diazepam, that is composed 5 mg 1 BD. Do USG pelvis to see if the fetus is alive. If yes, continue tablet Naturogest and tablet compose. Then add injection hydroxyprogesterone Fetugest 250 mg IM 2 per week up to 12 weeks, or injection progesterone ETS 100 mg 2 ml per 2 per week up to 12 weeks. Injection HCG Profaci 10,000 IU followed by 5,000 IU 2 per week up to 12 weeks. If not, refer the patient to a hospital for D&E, dilatation and evacuation, or laparotomy if the baby is not alive. It is important to explain the patient beforehand that only 50% of the threatened abortions conserved by above measures, remaining 50% lead to abortion. Next comes drugs for lactational control. To reduce or stop lactation, tablet bromocriptine, that is proctinol 1.25 mg BD for 3 days, then 2.5 mg BD. Tablet pyridoxine, that is B long 2 TDS, or tablet stilbestrol 5 mg 2 TDS for 4 days, then reduced to 1 TDS. Injection estradiol plus testosterone mixogen, that is mixogen 1 mg IM, useful if given early. Advise firm supporting brassiere or breast binder. Regular breast evacuation if congestion causes pain. This is to reduce lactation. Next, to increase lactation. If there is no better stimulation than regular suckling by the baby, lactation is insufficient if baby is failing to gain weight. If so, start tablet metoclopramide, that is Reglon 10 mg TDS, tablet desamino oxytocin butocin that is Butocin half hour before each feed, Shatavarix granules 2 TSF in milk twice daily, plenty of water. Poor water intake is common cause of poor milk quantity. Infertility and sterility. Infertility is not an individual's problem, it is a couple's disease. So even though it is the woman who approaches for infertility treatment, the couple needs to be treated. When should one investigate for infertility? Medically speaking, 12 to 18 months after consummate marriage, that is the period in which there were no contraceptive measures used by the couple for 12 to 18 months. Till then, reassure should be given but may not help under family pressures or their own wishes. Male partner, if history and symptom of impotency, premature ejaculation, start a tablet sildenafil citrate Viagra or that is Viagra 50 mg half hour before sexual intercourse. If genital examination reveals phimosis, hypospadiasis, varicocele, abnormalities of vas, epididymis or testes, refer to surgeon or urologist. If occupation involves exposure to high temperatures, advise change in occupation, stop alcohol and smoking, advise semen analysis. Semen analysis. The semen is best collected by masturbation directly into a dry and clean glass container. Fresh sample taken after 3 days of abstinence should be processed within 2 hours. Semen analysis should be carried out on 2 different occasions if the first test suggests impaired fertility. If the number of sperms is less than 60 millions per ml and or motility is less than 60% and or sperms of abnormal morphology are more than 20%, start with tablet clomiphene citrate, that is Clofert 50 mg OD for 3 months. If pus in semen examination, give Norflox 400 mg BD into 10 days or Ciplox 500 mg BD for 10 days plus tablet Doxy 100 mg BD plus tablet Metrogyl 400 mg. In azoospermia, refer for testicular biopsy. Infertility in female partner. If infertility with amenorrhea, treat as given in amenorrhea. If history, symptoms of hyperprolactinemia, discharge from nipples, tablet bromocriptine 2.5 mg HS increasing to 2.5 mg TDS. If past history, symptoms of tuberculosis, PID, peritonitis, appendicitis, do USG and refer. If history, symptoms of endometriosis, severe menstrual pain with menorrhagia, then refer. If history and symptoms of ovulation failure clinically or by USG, PCOD, post-pill amenorrhea, give tablet clomiphene citrate, that is Clofert 50 mg OD from second day of menses for 5 days. If successful ovulation occurs 7 to 12 days after the last day of treatment and coitus should be timed accordingly. If no response, increase the dose to 100 mg after 2 cycles. Refer if no success in 6 cycles. Watch for ovarian enlargement during this drug treatment by doing bimanual pelvic examination. Then both partners, the couple should be explained about ovulation cycle and fertile period. Conception is most likely between the 10th and 18th days of a 28-day cycle, at which the time advise coitus at 48-hour interval. Avoid using lubricants, these are often spermicidal. Avoid alcohol in excess, a long holiday is frequently an answer. Bye bye for discussing gynecology and obstetric conditions. Bye bye, thank you.